Welcome, and I'm going to speak about applications of the Arcscan VHF digital ultrasound scanner, originally designated as the Artemis technology. And I do have a financial interest in this technology, as I was one of the original developers of this Artemis technology, licensed to Arcscan by Cornell University. This very high precision 6 degrees of freedom scanner allows following of any of the contours of the anterior segment, so we can get extremely high resolution images of the epithelium or flap or caps, and the anterior segment, the angles, and also the posterior chamber. So we will look at these four areas: the epithelium, intrastromal measurements within the cornea, anterior chamber measurements, and of course the posterior chamber measurements, which are very relevant to ICLSizing. Remember that the epithelium was the first measured with high-frequency ultrasound and is still the most accurate way of mapping epithelium in vivo. Well, as described by my group about 20 years ago, we demonstrated that epithelial thickness profiles can be used to detect keratoconus even when the topography is normal, even when the tomography is normal, and in fact, with a higher sensitivity and specificity than OCT epithelial mapping, because it's 1 micron precision as opposed to 3 micron precision mapping. And the ability to detect keratoconus means that we will avoid doing LASIK on cases that would have developed ectasia. But what we also found was that the epithelial pattern can actually help us exclude keratoconus even when the topography looks keratoconic. And this leads to actually an increase in surgical volume, because one is able to rule eyes in to surgery that otherwise would have been excluded. Well, we've learned a lot about hyperopic corneal treatments from epithelial thickness measurements. And we now know that it is actually less useful to use keratometry as a measure of how much hyperopic steepening can be done on the cornea, and far more helpful to directly measure the epithelial thickness profile, knowing that it's the epithelial thinning in the central zone when we steepen the cornea that poses the limits to how much steepening can be done. And so many have become wary of treating hyperopia on the cornea because of measuring the wrong thing. We have shown that it is possible to have exceedingly high safety from +4 to +7 on corneal treatments if one uses epithelial thickness monitoring instead of keratometry as a measure of how much steepening can be done. And then finally, in cornea, the ability to measure the epithelium in 3 dimensions, the ability to map the stromal surface of the cornea, of a flap, of a cap in complex corneas, has led us to be able to do repair work that 20 years ago was thought to be impossible. It's practically any corneal complication of refractive surgery can now be restored to best spectacle corrected vision given epithelial and stromal thickness measurements. Now, with high-frequency ultrasound, we're able to look inside the stroma with actually higher measurement precision than with OCT. And that's because ultrasound interfaces are physical discontinuities, whereas optical interfaces by OCT require a refractive index change. And because the stroma is bathed in glycosaminoglycans, often these interfaces do not reflect well within, and you cannot see flap landmarks. So here's an example. Here you can see a cornea that has been scanned 10 years after microkeratome flap was made, and you can see that the interface is completely visible. And not only that, but it's visible in all the axes, so it's possible to do a 3-dimensional map of the flap or of the cap. And this is very important when predicting residual stromal thickness and retreatments. For example, here is a topography-guided ablation which was going to be performed under this flap by a colleague of mine who sent the patient for scanning, and we found that in fact the flap was about 260 microns thick in the middle, something that couldn't have been detected by the OCT. And likewise, if we're custom programming new flaps, here is a case of a smile procedure in which we have the smile interface, we have the epithelial thickness profile, and we can plan a LASIK flap exactly between the two, knowing the error bars, the standard deviation of the programming of the VisuMax, and be able to precisely determine the depth of a LASIK flap over the smile interface and under the epithelial thickness profile. Likewise, we can have complex corneas, such as in this free cap that was rotated several times without success in restoring best spectacle corrected vision, and the lock and key position was determined. Likewise, we can look at epithelial ingrowth in complex corneas and apical syndrome, complex scars, in order to make measurements and do planning of therapeutic refractive surgery. Of course, the anterior chamber has been visible to high-frequency ultrasound for quite some time. We're able to measure anterior chamber depth, angles, the angle to angle, and in glaucoma, this has quite a lot of applications because the MIGs and the micro inserts, the surgical anatomy around the angle can be delineated very nicely. But also, work that was done by Jack Coleman and his group in tissue characterization has been able to use tissue characterization to do acoustic biopsy of tumors. If we look at the posterior chamber, we know that the Arcscan is the only device in the world that can measure actually all of the lens in 3 dimensions. So for the first time, we're able to scan the entire capsule all the way to the equator in crystalline lenses and determine their position with respect to the zonules, which will help us with biomechanical analysis in accommodative IOLs. And of course, it enables us to know where we are, particularly when operating behind the iris. Operating behind the iris is considered to be obviously the dark side of the moon. And having our instrumentation go behind the iris without knowing the anatomy of where we're placing devices such as the ICLs can lead us sometimes into trouble. So let's move on to the risks of ICL surgery. We know that the ICL is an exceedingly safe lens. It's extremely safe technology with 3 million of these lenses already inserted around the world in the last 25 years. But we know that the complications are mainly due to sizing issues. We all know that oversized lenses can lead to angle closure, glaucoma, and even loss of vision, Uretz-Savalia syndrome, and serious problems such as pigment dispersion in the long term. We know that undersized lenses can lead to anterior subcapsular cataract, which leads to cataract surgery, which in high myopic eyes is actually a rather dangerous surgery because of the risk of retinal detachment. Yes, the hole has been introduced in the last years, but this does not mean that there are no cataracts, although there are reports of some long-term studies. We certainly have seen some anterior subcapsular cataract despite the presence of the hole of the aquaport in cases with low vaulting. So why is ICLSizing still a mystery? Why? It shouldn't be. The mystery comes from assumptions and the fact that everyone wants a quick solution here where there just isn't one. The fact is that when we're measuring white to white, it's quite far away from the sulcus to sulcus. Angle to angle is closer to the sulcus, and you can have eyes where the sulcus diameter and the angle diameter are very similar, but you can also have eyes where the sulcus diameter is larger than the angle. Likewise, you can have eyes where the sulcus diameter is smaller than the angle. And so these 3 different scenarios are, quite frankly, the obvious reason why ICLSizing is still a bit of a mystery, still a bit of a difficulty. This is not to mention the 4th factor, which is iris cysts. And we know that 30 to 40% of eyes in some studies have shown cysts in the ciliary body, and these can affect the position of the foot plates, which can change the tilting and the vault of the lens. So between these posterior chamber cryptic, hidden facts, we end up often with little crocodiles hiding under the surface that come up to bite us when we put an ICL in. So I'm now going to go through the 3 stages of scientific ICLSizing as practiced at the London Vision Clinic. and we start with the preoperative measurements in order to choose the optimal ICL size. My late great friend Carlo Lovisolo published a textbook of 500 pages in 1999 on the ICL, one of the earliest academics in this field. And he and I began working together using sulcus to sulcus measurements and showing that sulcus to sulcus based sizing was far superior to using white to white sizing. In a study we published, we showed that the predictability of the volt was far greater if using posterior chamber measurements than using white to white anterior chamber measurements. The chances of having a low volt and cataract or an exceedingly high volt and angle closure went down significantly by using posterior chamber measurements. Carlo also studied the biomechanics of these lenses, the compression characteristics of these lenses, knowing that the higher myopic lenses bend in a different way from the lower myopic lenses. And so he characterized all of this in a formula which he derived that was based on sulcus to sulcus and the power of the lens. But despite the fact that he described sulcus to sulcus sizing, Starr continued to use white to white, and Doherty, during the FDA trial, analyzed his results and also introduced a paper showing that sulcus to sulcus sizing was better than white to white. After which Kojima in Japan very cleverly introduced the concept of the sulcus to sulcus lens rise as another factor in affecting how much separation there was going to be between the implanted ICL and the volt above the crystalline lens. So we were using high-frequency ultrasound instead of lower-frequency ultrasound. Lower-frequency ultrasound is 30 megahertz. We were using 60 megahertz scanning with the Arcscan. And we were using the Kojima and the Doherty equations. So unfortunately, Carlo, who passed away from a glioblastoma, left us to continue the work, and we did. And we performed a series of studies, where we looked at a number of the measurements of the posterior chamber and trying to use these to correlate what would be the best way of finding what the predicted ICL size should be. What we found was that the ciliary body inner diameter and the sulcus to sulcus and the scotopic pupil pre-op, these three measurements were exceedingly powerful at predicting what the lens separation would be after installation of an ICL. What was interesting is that the sulcus to sulcus measurements, which was previously the best way, turned out not to be able to be kept into the formula when the ciliary body inner diameter was there. So the ciliary body inner diameter, in fact, is the strongest way of predicting volt height. Ciliary body inner diameter now has really surpassed any other of the posterior chamber parameters in terms of determining the size of the ICL that should be implanted. And so with these three parameters, we now have a formula that, rather than recommending a particular size of lens to be put in, which is what the Starr, Lovisolo, Kojima formulas do, our formula will give the user what the volt height will be for each of the four sizes available, given the three parameters of the ciliary body inner diameter, the scotopic pupil size, and the sulcus to sulcus lens rise. Of course, we have to remember that OCT and machine learning has now come into the fold, and the lasso learning machine methodology applied by Kim, the Russo formula on the MS39 with an integrated tool, which gives us a predicted volt with a particular ICL size. And a number of machine learning publications now are in the literature. All of these AI OCT device formulas, of course, are still using anterior chamber dimensions in order to predict posterior chamber dimensions. And of course, this is quite different from using posterior chamber dimensions. Now, many of you have already used this website. We set this up like an ASCRS calculator concept for like for IOL calculations, what we're doing it for ICLs. And if you enter all of the parameters that one can enter from anterior chamber, it will give you the Kojima, Doherty, Nakamura, and the London Vision Clinic formula for ICLSizing. That will, of course, depend on the ciliary body inner diameter and the scotopic pupil and the sulcus to sulcus lens rise. Now, in our training set for ciliary body inner diameter, we first did a series of 42 eyes and then 78 eyes in order to refine the coefficients. We performed an analysis which gives us the sulcus-based ultrasound formulae compared to the angle-based OCT formulae compared to the OCOS formula, and that was then compared to the Reinstein formula. Here you can see the training set using high-frequency ultrasound, but using the Kojima formula. And you can see we had a mean central volt of about 500 with an interquartile range of 390 microns. Formula 1, 42 eyes, the interquartile range went down to 169, and with Formula 2, this went down to 131. Now, if we compare these two equations together, put all the eyes together, that was an interquartile range of 155 microns. Compared to all the other formulae, you can see that we had far better predictability using posterior chamber ciliary body inner diameter than the sulcus-based formulas, the angle-based formulas, and certainly the white-to-white. The bottom line here is that the posterior chamber derived ciliary body inner diameter formula outperformed all other formulas significantly in terms of predicting the volt height once the ICL was implanted. Now we know that around the world people are still using white-to-white, and here is a table comparing the different formulas, sulcus, anterior chamber, and the Reinstein formula with the star formula. And you can see that the star formula is still being used, and in 17% of eyes, the star formula will suggest a lens that is 2 sizes larger than that suggested by the Reinstein formula. So this explains why there can be some significant overvolts with using white-to-white sizing. Just to show you an example, here is one of our early spreadsheets where you can see all of the formulas predicting what lens should be used and the Reinstein formula. We used our calculator, and you can see that based on our measurements, the 12.6 was what was suggested by a predicted volt of 568 or 547 in the left eye. What did we actually get? We actually got 821 and 759 microns. This means that the volts were approximately 250 microns higher than expected from the Reinstein formula. Well, okay, but if we had used the star suggested lens, which would have been the 13.7, and according to the Reinstein formula, the predicted volts would have been over a millimeter, with the extra 250, this would have resulted in a 1350 volt. So we ended up with about 800, which is okay, but if we'd ended up with about 1350, we probably would have ended up with bilateral exchanges. This is an attempted volt versus an achieved volt graph, and these are not graphs that you've seen many before because most formulas don't provide a prediction of the volt. Now they're starting to do that. Now, if we look at the predicted volts with the Reinstein formula, we had 61% of the eyes within 100 microns of predicted, with 96% of the eyes within 300 microns of predicted. Now, if we just look at the 100 micron predictability, and we see that the star formula using white-to-white only got less than 20% within 100, yes, OCT did better, more 25 to 30% within 100 microns, but nowhere near as good as using posterior chamber dimensions. Measuring directly into the posterior chamber is better than measuring from the posterior chamber, trying to predict the dimensions of the posterior chamber. And remember that this Reinstein formula is available at ICLSizing.com, free for anyone to use, free of charge. And it also enables you to enter all of the other anterior chamber parameters so that you can compare the different formulas to the Reinstein formula. So let's just remember that measuring directly in the posterior chamber is what makes the most sense when choosing ICLs. It's completely logical, because not only are you going to be measuring where the lens is being put, but you're also going to be detecting the cysts. So while white-to-white works well, you can use white-to-white, you're going to get away with it most of the time, there's still going to be a number of outliers which are going to lead to exchanges. If we use OCT, we are closer to the posterior chamber from the anterior chamber, and so yes, we're going to get a tighter distribution of the volt control, but we're still going to have the outliers because there's still going to be the crocodiles under the surface of the iris. And so it seems obvious that if we are measuring behind the iris directly where the ICL is going, this is our best chance of not only reducing the outliers or perhaps even eliminating the outliers. And, pictorially, this is kind of obvious. You can, sail along and do quite well with your white-to-white. Or you can use an OCT and you will find less trouble. But if you really want to find all of the trouble and avoid all of the alligators, you need to go with high-frequency ultrasound. Bronze is the metal for white-to-white, silver is the metal for OCT, and high-frequency ultrasound of the posterior chamber is by far logically and now demonstrably, scientifically, I have shown you that it is the very best way of sizing ICLs. If one is not doing it this way, one is not doing it in the best way. Now, I had a very interesting question from Professor Idzbecka in Poland. She was using the Quantella Viso, which is 30, 40 megahertz scanner, and she wanted to use our formula. And she used our formula with their scanner and found that she was very, very happy with the volt control, because with white-to-white, she was getting about 20% within 100 microns and about 40% with her UBM. Now, this is, of course, better than white-to-white, but it is nowhere near as good as the results that we showed with 60 megahertz robotic high-frequency ultrasound scanning. Again, emphasizing the fact that measurements with high resolution in the posterior chamber are the very best way of sizing the ICL. Now, that's all of the predicted, picking the right lens. Let's now move into phase 2, because it's biology, and sometimes even the best predictions are going to have errors. Now, we know from a number of studies, including ours, that the positioning of the foot plates is not always where we think it's going to go. This has actually altered my surgical technique in forcing the foot plates down behind the iris into the lowest position possible with an instrument after inclavating the foot plates behind the iris, because I want to make sure that the foot plates are as low as possible and that they're not producing a variability in the volt control. My son Max Reinstein did this project last summer where he used our intraoperative OCT, the Artivo 800, and we measured the volt and the pupil size intraoperatively. And he derived a correlation between the intraop volt measurement and the 1 month volt. And he found that actually some eyes come down, but some eyes go up. On average, the amount of volt goes down by about 200 microns between the intraop measurement and the 1 month measurement. But sometimes it goes up. And so he performed a multivariate regression analysis model. And he found with his formula that from the intraoperative measurement, one could predict the postoperative volt to within 320 microns in all of the eyes using this multivariate regression analysis. So we're now using this intraoperative measurement. We make the measurement intraoperatively, and we have the pupil size during the surgery. We tell us what the target we think is going to be for this lens based on the CIBD formula, but the predicted volt will be determined by this intraoperative multivariate regression. It also gives us a 95% confidence interval. So in this particular case, the chances of the volt being above 1 millimeter are actually quite high. And so in this particular case, based on this formula, I decided to extract this ICL on the table and place the next size down, making it one surgery for the patient instead of two. Technically, obviously, an extraction and a repositioning of a different lens, but it's only one visit to the operating room. And that's because of the risk of this volt not coming down predicted by this formula. Finally is the postoperative monitoring. And I want to show you here the sort of day that I have usually when I'm looking at the 1 month post-ops. So here's an example of the predicted volts from our Reinstein formula, and this is the achieved volts. As you can see, these are the population statistics of the right and left eye, the distribution of all of the different parameters. Here's another example, predicted around 450, achieved around 450. Predicted around 550, achieved around 550. Predicted around 500, same, 450 and 560, almost exactly as predicted. And remember that the central volt is not exactly the most important volt, particularly in high myopic ICLs, because the thickest part of the ICL is actually in the mid-periphery of the lens. And so the volt separation is actually tightest in where it is behind the iris, something that we cannot see. And if you want to see that with OCT, you have to dilate the pupil, but you can't do that because if you dilate the pupil, the lens moves forward. So the only way to know the physiological separation of the lens in 3D is with ultrasound. And remembering that the zonular position, the ciliary body position, the sulcus position of these foot plates can actually affect foot plate position by 200-300 microns, it is important, we think, to be able to monitor the lens separation post-op. So Arcscan has enabled us to be able to have a map of the volt. As you can see, low volt on this side, high volt on this side from a tilted lens. A tilted lens because the foot plates in this particular case were not positioned in the lowest possible position after I inserted it. So in conclusion, preoperative determination is obviously the most important part of ICLSizing. Intraoperative confirmation with an OCT can enable us with a multivariate regression formula to be able to predict the postoperative volt at the 1 month mark and decide whether an exchange on the table is indicated. And finally, being able to postoperatively monitor the lens separation behind the iris may help us in the long term for long-term safety. Again, ICLSizing.com is free for use to anyone. And again, let's remember that the Arcscan device is extremely versatile with the highest accuracy epithelial measurements, the ability to measure intrastromally, all of the interfaces for therapeutic refractive surgery, anterior chamber dimensions, and of course, most importantly, the posterior chamber and the ability to size ICL in the 3 stages in order to make the ICL into what is an extremely good technology into a bulletproof technology. And I thank you very much for your attention.